Welcome to the deep dive. Today, we're really zeroing in on retinitis pigmentosa, or RP, as it's often called.
That's right.
Think of this as your sort of high-yield guide. We want to cover the absolute must-knows about this condition. Perfect if you need a clear, concise overview, maybe for revision.
Exactly.
Yeah.
And it's really important to grasp from the start that RP isn't just one single thing. It's actually a group of inherited conditions.
A group. Okay.
Yeah. And unfortunately, they all lead to progressive vision loss. It often creeps up on people, maybe starting with trouble seeing in dim light, but it can, eventually lead to quite significant sight impairment.
So for this deep dive, we've basically sifted through a load of revision notes looking at definitions, causes, risks, how it works, diagnosis, management, the whole lot. Our mission really is to pull out that core info on RP in a way that makes sense and hopefully actually sticks.
Yeah, make it memorable.
Okay, let's dive in. When we say retinitis pigmentosa, what's the fundamental picture we should have?
Well, at its core, RP is about genetics. It's a collection of these inherited disorders.
Right.
And the key thing happening is the progressive breakdown, the degeneration of the photoreceptor cells in the retina.
Those are the light-sensing cells.
Exactly, the ones that let us see. And a real hallmark, especially early on, is that this breakdown usually starts out in the periphery of the retina.
Ah, the edges.
Yeah, which is why people often end up describing that feeling of tunnel vision developing over time.
Tunnel vision. Yeah, that's quite a powerful description. Okay, so what actually causes this breakdown? What's the etiology here?
Fundamentally, it boils down to genetic mutations. Tiny errors in the genes
Okay.
that mess up how the retinal cells are supposed to work.
Yeah.
What's really interesting, though, is how varied the inheritance patterns are.
How so?
Well, you've got autosomal dominant, where just one faulty gene copy is enough.
Right.
Then there's autosomal recessive, needing two copies, X-linked, where it's carried on the X chromosome. And you even get what we call sporadic cases, people who develop RP without any obvious family history.
Wow. Okay. It's quite a mix. And are there specific conditions often found alongside RPP, sort of package deals almost?
Yes, definitely. There's several really important associations to know. Think of Refsum disease.
Blindness. Okay.
Yeah, maybe picture someone a bit wobbly, that's cerebellar ataxia, pins and needles, peripheral neuropathy, maybe hearing loss, deafness, and that dry, scaly skin, ichthyosis.
Got it. A multi-system thing.
Exactly. Then there's Usher syndrome. That's the classic link. RP plus hearing loss. Very key association.
Usher. Vision and hearing.
Right. And others too, like abetalipoproteinemia, Laurence-Moon Beetle syndrome, Kearns-Sayre-Alport syndrome. Knowing these links can be super important for the bigger diagnostic picture.
So it's definitely not always just an eye problem. When thinking about risk, then, is it mainly about that family connection?
Largely, yes. Given its inherited, family history is the biggest risk factor, for sure.
Makes sense.
But like we said, those sporadic cases mean it can pop up without a known family link. And genetic testing can be really useful here. It can help pinpoint the specific mutation, which helps assess the risk for others in the family, even if the history wasn't clear before.
Okay, right. So we know what it is, what causes it. Let's get into the mechanism. How does it actually unfold in the eye, the pathophysiology?
So it's this slow, progressive decline of both types of photoreceptors, the rods and the cones.
Rods and cones, okay.
Yeah. Rods are key for night vision, peripheral sight. Cones handle central vision and color. Typically, the rods are hit first.
Ah, hence the night blindness early on.
Exactly. Think rods for night and sides. So when they malfunction, you get that initial night blindness, and the peripheral vision starts to narrow.
Right.
Then later on, the cones can get involved too, and that's when central vision and maybe color perception can start to decline.
And if you were to, say, look inside the eye with an ophthalmoscope, what changes would you see? What's the pathology?
It looks quite distinctive, actually. A key sign is pigmentation changes in the retina, often described as looking like bone spicules.
Bone spicules,
Yeah.
like tiny bone shapes.
Yeah, sort of dark, spiky deposits, usually scattered around the periphery. You also see arteriolar attenuation. The retinal blood vessels look thinner than they should.
Okay.
And in later stages, the optic nerve might start to look pale, showing atrophy. That pigmentation, by the way, is thought to be pigment cells from the epithelium migrating into the neuroretinal layers.
Disrupting things.
Exactly.
Yeah.
And as those photoreceptor cells die off, the blood vessels thin out because there's less metabolic demand.
Makes sense.
And remember, while it varies, it's often the rods that show dysfunction first. It's also worth mentioning that the inheritance pattern can sometimes hint at severity. X-linked often tends to be more severe and progress faster,
Right.
whereas autosomal dominant might be milder, slower. Autosomal recessive is pretty common. And again, those isolated cases happen too.
Okay, so those are some key visual clues. But given that symptoms like vision loss can occur in other conditions, what else might be on the list? What's the differential diagnosis?
Oh, that's a crucial point. You definitely need to rule out other possibilities. The list is, well, pretty extensive.
Okay.
You have to consider other inherited retinal dystrophies generally. Things like cone rod dystrophy, Leber congenital amaurosis. Usher syndrome is a big one, given the overlap.
The hearing loss connection again.
Exactly.
Yeah.
But it goes beyond the retina, too. Things like Friedreich's ataxia, mucopolysaccharidosis, even certain types of muscular dystrophy like myotonic dystrophy.
Wow.
Also Batten's disease, Bassen-Kornsweig syndrome, even metabolic issues like homocystinuria or oxalosis.
So really broad.
Yeah, and then you have things like trauma, glaucoma, especially if it causes pigment changes, and even drug toxicities like from long-term chloroquine or thiordazine use.
Right.
Or infections like late-stage syphilis affecting the retina, or even rare cancer-related retinopathy. It's a wide net you need to cast initially.
Definitely sounds complex. Okay, stepping back a bit, how common is RP? What's the epidemiology look like?
In the UK, the current estimate is around 1 in every 4,000 people.
1 in 4,000. So not super common, but certainly not vanishingly rare either.
Exactly. And importantly, it affects people across all ethnic backgrounds and genders. It doesn't discriminate.
Okay, so let's bring it back to the patient experience. What are the main symptoms they report, and what key signs does a clinician look for? The clinical features.
Right, so the patient journey often starts with noticing difficulty seeing at night or in dim light that night. Blindness or nyctalopia is really often the very first symptom.
The classic starting point.
It really is. Then, progressively, they'll notice their peripheral vision closing in. That leads to the tunnel vision we mentioned.
Which must make things like getting around difficult.
Hugely. Navigating crowds, even just walking around unfamiliar places, driving, of course, becomes increasingly challenging. They might also mention their vision isn't as sharp, overall decreased visual acuity, and maybe colors seem less vibrant or harder to distinguish.
And on examination.
Well, the absolute hallmark sign is a bone spicule pigmentation, those dark clumps, typically seen out in the peripheral retina.
Right, you mentioned that.
And alongside that, you often see that the retinal arteries look narrowed or attenuated vascular narrowing.
When does this usually start?
Typically, the onset is in childhood or adolescence, often with those night vision issues being the first clue. Then the peripheral vision loss creeps in gradually. Central vision might be spared for a long time, but it could eventually become affected too. But a really key thing is that the age of onset varies a lot depending on the specific genetic type of RP. It's not one size fits all.
And we touched on this, but sometimes RP isn't alone. It's part of a bigger picture, a syndrome.
Absolutely.
Yeah.
It can definitely occur as one feature of a wider syndrome. Usher syndrome is the classic RP plus hearing loss. Remember, Usher in the dark and can't hear.
Good mnemonic.
Yeah. Others include Waardenburg syndrome, Alström's, Alport's, Refsum's disease.
The one with the ataxia and skin changes.
That's the one. And even beyond name syndromes, you can see RP associated with other things like short stature, kidney problems, extra fingers or toes, like in Bardet-Biedl or Laurence-Moon syndrome.
Right.
Or it might be part of a mucopolysaccharidosis, like Hurler's, or a mitochondrial disorder, like Kern-Serre syndrome. Yeah. So diagnosis really involves looking at the whole person, not just the eyes.
Makes sense. So if someone comes in with these kinds of symptoms, what investigations nail down the diagnosis?
Well, it starts with a really thorough eye exam. That means checking visual acuity carefully, doing visual field testing that's essential to map out the peripheral loss.
Okay.
A detailed look at the back of the eye, the fundus, checking pupillary reflexes, testing color vision, and doing a refraction to see if glasses help at all.
Standard checks.
Yeah, but crucial. Plus measuring the eye pressure, intraocular pressure, mainly to rule out glaucoma, which can sometimes mimic certain features.
But imaging.
Imaging is important too. Retinal photography helps document those characteristic findings, like the pigmentation. Ultrasound can look at the eye structure. Fluorescein angiography assesses blood flow. And OCP, optical coherence tomography,
OCP, yeah.
that gives amazing cross-sectional images of the retinal layers, showing the thinning and disruption.
But you mentioned one test was particularly key.
Ah, yes, the electroretinogram, the ERG. This is absolutely essential for diagnosing RP.
The ERG, what does it do?
It measures the electrical response of the rods and cones across the whole retina when you flash lights at the eye.
Okay.
In RP, The ERG typically shows a really marked reduction in the signals from both rods and cones. Often, the rod signals are much worse, which fits with the early night blindness.
Confirms the photoreceptor dysfunction.
Precisely. There are newer techniques, too, like adaptive optic scanning laser ophthalmoscopy, which can actually see damage to individual photoreceptor cells very early on.
Yeah.
But for diagnosis, the ERG is the workhorse, usually done in specialized centers.
Okay, diagnosis confirmed via exam, imaging, and that crucial ERG. What happens next? What's the management plan?
Right. The first thing to be really clear about is that, unfortunately, there's no cure for RP at the moment.
Okay, managing expectations is key.
Absolutely. So the focus of management is really threefold. Trying to slow down the degeneration, making the most of the vision the person still has, and providing really good support.
How do you do that?
Well, referral to a low vision specialist is vital. They coordinate multidisciplinary visual rehabilitation.
What does that involve?
Things like training in using low vision aids, magnifiers, telescopes, special lighting strategies for daily living, mobility training, maybe career support. It's very practical.
Okay.
And regular eye checks are crucial to screen for and treat complications that can crop up, like cataracts, glaucoma, or swelling in the maculocystoid macular edema.
Right, those associated risks.
Exactly. And protecting the eyes from potentially harmful UV light is generally recommended, so good quality sunglasses are important.
What about the genetic side of things?
Genetic counseling is essential. It helps the patient and family understand how the RP is inherited in their specific case, what the risks are for relatives, and options for family planning. Examining family members can also be part of the picture.
And the psychological impact. It must be tough.
Incredibly tough. Living with progressive vision loss takes a huge emotional toll. So access to counseling and psychological support is a really important part of management.
Practical things too, like driving.
Yes, definitely. There are legal requirements, certainly in the UK, to inform the DVLA if your vision drops below certain standards. There's specific visual field testing required by law for driving.
Okay. What about new treatments? Any hope on the horizon?
Yes, this is where things get more exciting, though still often in the research phase. There are lots of clinical trials happening.
For what kind of therapies?
Gene-specific and mutation-specific therapies are probably the most promising area right now for certain types of RP. The idea is to correct the underlying genetic fault.
Wow, targeted treatment.
Exactly. There are also more experimental approaches being explored, like transplants of retinal pigment, epithelium cells, stem cell therapy, and even retinal prostheses, bionic eyes.
Still experimental, though.
Largely, yes, but advancing. And for some very rare syndromic forms of RP, like abetalipoproteinemia or Refsum's disease-specific dietary changes, are actually a key part of management.
Tailored diets for specific types.
Correct. But for most common forms of RP, things like acetazolamide, supplements like lutein or bilberry, the evidence for benefit is pretty limited.
What about vitamin A? You hear about that sometimes.
Yeah, vitamin A and fish oils have been studied, but overall there's no clear, convincing evidence that they provide a significant benefit for the majority of RP patients. High doses might be considered in very specific rare conditions, but that's specialist territory.
Right, and surgery, besides those experimental things.
Surgery mainly comes into play for managing the complications, so cataract surgery if cataracts develop, or sometimes surgery for keratoconus if that occurs alongside RP.
Okay, so it's a mix of supportive care, managing complications, and hoping for those research breakthroughs. What's the general outlook, the prognosis?
It's really variable. That's the key message. It depends so much on the specific gene mutation and how quickly the disease progresses in that individual.
So hard to predict.
Very. Some people maintain useful vision for many decades. Others, unfortunately, particularly with more severe forms, can experience significant visual impairment or legal blindness, sometimes relatively early.
But good management helps.
Definitely. Regular monitoring, early intervention for complications, good low vision support, all of that can significantly improve quality of life, whatever the underlying progression rate.
And finally, just to recap the main complications we need to watch out for.
Sure, the primary one is obviously the progressive vision loss itself and the difficulty that causes with daily life. Then there's that increased risk of developing cataracts, macular edema, that swelling at the back of the eye, and glaucoma, which just underlines again why those regular eye exams and proactive management are so important to catch and treat these things early if they arise.
Okay, great. So let's try and boil this down. Retinitis pigmentosa It's a group of inherited conditions. It's progressive, typically starts with night and peripheral vision loss. How fast it goes and how severe it gets varies hugely based on the genes involved.
Exactly.
No cure yet, but management is all about slowing it down, maximizing the vision they have, providing support.
Crucial support.
And keeping an eye on complications. And there's definitely real hope coming from ongoing research, especially in gene therapies.
That sums it up nicely. And, you know, if you are studying for the MSRA or just want more of these kinds of high-yield reviews, definitely check out passmsra.com.
And there's also freemsra.com for free resources, too.
That's right. Both great places to look.
Perfect. Well, thanks for joining us for this deep dive into retinitis pigmentosa.
My pleasure.
We'll catch you on the next one.